Welcome to another episode of Three Plastic Surgeons and a Microphone. Today, we are, as always, we are with Dr. Sal Pacella from La Jolla, California. His Instagram handle is @SanDiegoPlasticSurgeon. Also, Dr. Sam Jejurikar from Dallas, Texas. His Instagram handle is @SamJejurikar. And I am Dr. Sam Rhee from Paramus, New Jersey, and my Instagram handle is @BergenCosmetic. How are you guys?
Wonderful.
Doing great.
Awesome. As always, this show is not a substitute for professional medical advice, diagnosis, or treatment. The show is for informational purposes only. Treatment and results may vary based upon circumstances, situation, and medical judgment after appropriate discussion. Always seek the advice of your surgeon or other qualified health provider with any questions you may have regarding medical care, and never disregard professional medical advice or delay seeking advice because of something in this show. Dr. Pacella, you're wearing sunglasses today. Is it night there? Is this like that Corey Hart song?
No, we got to wear sunglasses because our future's so bright. We have to wear shades.
Yeah.
Getting back to the 80s again. So, well, good segue. So the whole reason I'm wearing sunglasses is, guess what? Why? Because we're talking about skin cancer, gents. All right. And it's important to understand and I'm going to get back to this in just a second once we talk about our cases. But today's episode, we're going to talk a bit about skin cancer and skin cancer reconstruction. This is a topic that is exceptionally close to my heart. It's a passion of mine. I work with a group of dermatologists that roughly, honestly, I probably do about 30 to 40 cases a week sometimes dealing with skin cancer reconstructions. And, tell us, gents, what's a little bit about skin cancer in your area and what you tell your patients for sun protection.
Obviously, much like you see in San Diego, Dallas is a place where the sun is bright, and there's a large segment of patients that just haven't paid enough attention to skin cancer or prevention of skin cancer with the use of sunscreen. Mm-hmm. Probably the biggest advice that I will tell patients is you have to wear sunscreen. You have to think about it and make it part of your regimen when you leave the house every day. Sunscreen, not just on your face, not just on your hands or your arms, but over your entire body. And that's got to be part of your daily regimen. Prevention is the key, because many times, exposure that you get now is going to pop up 10 or 15 years later as skin cancer. And so it's what you're doing now will have huge benefits in the future.
In New Jersey, we also have a significant number of people that do indoor tanning. I think it shifted to spray tanning, but there's still a significant number of people that will do UV tanning.
Jersey Shore, baby. Jersey Shore.
That's right. You got to get that base before you go out there in the summer. And so we do see a lot of skin aging from that regard. And then also, like you said, the older population, I mean, our generation and older, they used to just throw some baby oil on us and then let us burn that first, sunny day, and then just build from that. So, so there's a fair amount of skin cancer as well.
Okay. So for our viewers out there, skin cancer is exceptionally common. In fact, it is the most common form of cancer that's diagnosed in this country. Globally, it accounts for over 40% of cancer cases. So this is, we talk about pandemics. This is a global pandemic that we see. Over 90% of skin cancers are caused or worsened by exposure to ultraviolet radiation from the sun. So that's why, a couple episodes back, we talked about our skin care and skin protection. We talked about utilization of sunblock, and that's why the choice of sunblock is so critically important. Some of those sunblocks that are made of avobenzone, or some of the ones that can dissipate over time in the water, don't block a substantial portion of both UVA and UVB. The only sunblocks that block the entire spectrum are reflective sunblocks like zinc and titanium. So this is just a huge, huge concept. Gents, tell me a little bit about what you recommend for your patients as far as sunblock specifically, or sunscreen, I should say.
Like which products in particular they should get?
Are there any products that you say or that you recommend specifically?
I just sent him down to Nina in our skincare center, who you met a couple episodes before.
Right.
Well,
Exactly. It's great.
Exactly.
Actually, I mean, I learned from Nina too, and I think that some of the physicals blocks, like you said, the zinc and the titanium oxide, come in micronized forms, which are very natural appearing, and they have tints. And Nina mentioned them, and those are actually very good ones to use on a daily basis.
Right. So, it's important for our readers to understand also too that about 20 to 30% of skin cancers that are out there actually come from pre-existing moles. So if you have a pigmented mole or a non-pigmented mole, there's a substantial risk that throughout your lifetime that that mole may turn into something that's dangerous. Now, when we talk about skin cancers, we're really referring to two different types or subclasses of skin cancers. There are what we call melanoma skin cancers, obviously. Those are dangerous. Those, you can die from those. And then there are non-melanoma skin cancers, cancers such as basal cell carcinoma or squamous cell carcinoma. They're substantially less aggressive. It's exceptionally rare to die from those, but I have seen those in patients that have ignored some of those cancers. They can erode through vital structures, lead to infection, and sometimes, unfortunately, lead to death. So these are really important things to understand. So I urge all our viewers, regardless of your skin tone or your skin color, you want to have a really good relationship with a dermatologist. Every 6 months or every year, you should really have a full body exam. There are great dermatologists out there which will take photographs of your entire body. They'll check moles out and really sort of examine this throughout your lifetime. Gents, do you each of you see a dermatologist?
I have a dermatologist that I see probably once a year.
Mm-hmm.
I think I saw one a couple of years ago, but not recently, no.
Yeah, so two plastic surgeons that are in tune to what's going on in the skin, but not seeing your dermatologist.
I see my dermatologist once a year.
Okay.
How often should I be seeing my dermatologist?
No, you're right. You got a little bit of pigment in your skin, so you have a little bit of protection. Those of us that are a little bit more fair skinned have actually a higher risk of developing skin cancer than those with pigment in your skin. The other important thing to understand is just looking at the numbers here. So melanoma, although we hear a lot about it, it's relatively rare. In the U.S., there's only about 250,000 patients a year that are diagnosed with melanomas, and very few of those will go on to be metastatic melanoma or melanoma that spreads to other parts of the body. On the contrast, non-melanoma skin cancers, there's roughly about 2 to 3 million cases diagnosed per year. So really, really substantially high risk, particularly for those of us that have exposure to sun. So, gents, anything to add?
Well, some of us don't surf like 3-4 days a week. So
exactly. You're an outdoorsman. I'm more of an indoorsman, so I have more protection.
Yeah. So that's interesting. I do surf quite a few days a week, and I'm just as guilty of anybody as the not putting on sunscreen when I should. The biggest issue is, just the access to it. I hate to say, it's sitting on my counter. Keep it a little tube like this. It's a little stick on, and if I go out there, I remember I put it on. But I should probably be leaving it in my car, but it melts as a stick. So I really should be doing a better job. So another interesting story is, I went out, this summer, I was surfing quite a bit more than now in the fall. And, I found myself really getting exposure to the top of my head here. And I'm clearly losing a little bit of hair here. And it's exceptionally challenging to keep sunblock on your scalp. It's just not feasible to run it through your hair and kind of rub it in. It's hard. So, I started surfing with a hat, and, I just bought a bunch of cheap hats and rigged in a little bit of a chin device to sew in so that, if I lost it in the surf, it's not too big of a deal. So, that sun exposure is huge right in the water. It can be reflective right off of the water. So, So great. Well, I'm going to go and I'm going to start sharing my screen here. So let's go ahead, and I want to show you guys a couple of cases here. All right. Okay. All right. So you guys can see this here, right?
Yep.
Yes.
Okay. So, so we're going to talk about skin cancer reconstruction. So, again, I mentioned this was a big passion of mine. I was inspired by my colleague, Dr. Mark Kodner, and he and I actually have a textbook that we've published several years ago on aesthetic facial reconstruction after Mohs surgery. Mohs surgery is a specific way of removing cancers. And let's see here. Okay. So, so one thing I want to determine here, as many or chat with the audience about, is what is Mohs surgery specifically? So many plastic surgeons out there, particularly in the older community, may say, well, you got a little skin cancer on your lip or your eyelid or somewhere else, and I'm just going to cut that off and close it directly. Okay. But the specifics of curing a patient from that cancer is something very nebulous to us as plastic surgeons. So what I want to really point out here is, when you go see a plastic surgeon or a facial plastic surgeon or an oculoplastic surgeon, and they don't do Mohs surgery, this is the pathology. This is the way the pathology is processed. It's usually taken out in an ellipse. So if we have a tumor, there's no way for the surgeon to identify with their eyes how deep that tumor is. So if you take it out in an ellipse, I naively thought that when I started practice, well, the pathologist will slice it into tiny, tiny little slices. But that's not actually what happens. What the pathologist will do is they'll take interval slices. So if you see this diagram right here, what you see is they'll take several slices at intervals of this bread loaf, if you will. And those are very thin slices. And when those slices are examined under the microscope here, this slice under A, you can see there's no cancer. This slice under B, you can see that then there's no cancer going at the margin. The slice under C, you can see a margin cancer here. But the problem here is there can be extension of the tumor in between two slices. So you can easily see how there could be a phenomenon where we do this ellipse, we send it to the pathologist, we get a clear margin, but technically speaking, it's not a clear margin because it didn't examine a slice that was taken. So traditional pathology, when you remove skin cancers, is only about 68% effective in curing the cancer. Now, with Mohs surgery, this is done by a specific team or of dermatologists. And what they do is they cut out these cancers in a pie. So this pie format allows the surgeon or the dermatologist to examine the slice, and they can say, well, look here, at 1 o'clock, we've got a positive margin, we can go back. So Mohs surgery is designed to remove cancers and examine 99% of the margin. So it's 99% effective. And so what happens is this creates several defects around the face or otherwise. So here's an example of an older lady. She's in her 70s. And you can see here she had a skin cancer removed from her eyelid. Okay, now this was a fairly extensive basal cell cancer. Basal cell cancers are very, very common in the eyelid. Now, if you recall, when I was at the beginning of our episode here, I was wearing some sunglasses. Okay. Now, let me ask you both, gents, a question here. When you guys go out in the world, do you put sunblock on your eyelids?
No.
No, I do
Right.
not.
Right. No one ever does, right? Because why? Because it stings the eyes. I have a fight with my kids all the time when they're going out in the world, right? We got to put sunblock on your eyelids. Why? Well, if you think about how sunglasses specifically are designed, they have a curvature or convexity to them. So when sun hits on the opposite surface of the sunglass, what happens is that creates a convex surface, and those glasses can actually focus UV rays directly on the lower eyelid because of sunglasses that we wear. So it's important to use sunglasses, but put on sunblock to your lower eyelids as best as you can. So this lady unfortunately developed a skin cancer. She had it resected. This is about 3 rounds of Mohs surgery. And you can see here, it took about 80% of her eyelid off. So gents, tell me a little bit about, obviously, both of you are not, don't do a ton of reconstructive surgery, but you have had this in your training and did it earlier in your practice. So tell me how you would approach this here.
I would send them to Dr. Sal Pacella.
So a couple of things before I get into this. I want to thank you for the explanation about the benefits of Mohs surgery versus a traditional elliptical excision. I think that was the most clear explanation I've ever actually heard about why processing skin cancers through Mohs is superior to the standard elliptical excision. And I bet most plastic surgeons don't even know that. So that was very beneficial. In all seriousness, this is not a case that I would do because for our viewers out there, this looks complicated, but for the plastic surgeons that may be watching this, they all recognize this is incredibly complicated. And when you look at an eyelid defect like this, you have to think about basically 3 things that you're trying to reconstruct. You're trying to reconstruct the inner lining of the eye, which is called the conjunctiva, or basically the skin of the inside of the eyelid. You obviously have to reconstruct the skin on the outside. Then you actually have to bring about some form of support in the inside of the eyelid as well, some form of structural support. And there's a variety of complex ways to do this. And there are surgeons like Dr. Pacella who do this on a multiple times a week basis. And there are surgeons like me and Dr. Rhee who did this during our training 15 to 20 years ago. The form of reconstruction that would be involved is going to involve Dr. Pacella having done multiple different flaps, likely having used a graft of some kind to recreate the lining of the inside of the eyelid. But it's a complicated, multiple steps to the first reconstruction, and then multiple steps down the road to contour it and fix it. So I'm excited to see what he actually did.
All right, great. Dr. Rhee, any comments?
I was just thinking about how Sam addressed that, and that would be exactly what I would do for an oral case presentation. That was perfect. Like, if I was a resident and I had to answer that, I would do exactly what Sam did, was describe the issue, describe the general strategy, but then try to come up, finagle some of it like that, and that's why Sam did so well in residency. He was such an analytical and good talker. I love that.
I know what I know, and I know what I don't know.
Right. So for the viewers out here, they are correct. Not the average plastic surgeon in the world would be doing a case like this. I did a specific fellowship in oculoplastic surgery. I feel very comfortable in and around the eyelid for both cosmetic surgery of the eyelid and reconstructive surgery. So this is a case I really, really, truly enjoy. So, okay, so let's go on. So the choice of reconstruction that I chose here is a common technique in oculoplastic surgery called a Hughes flap. And so what that is there is a skeleton to the upper and lower eyelid. And that skeleton is called the tarsal plate. And it's about 6 millimeters thick on the lower eyelid and about 8 millimeters thick on the upper eyelid. So this lady had a complete disruption and destruction of her lower tarsal plate. So what we did was, we're actually going to use a piece of the upper eyelid to reconstruct the lower eyelid. So what we do is we flip the eyelid on itself and then cut right longitudinally through the middle of the eyelid on the inside and bring this little membrane down. This is called the tarsal plate, and it's attached by a membrane of tissue. So we're bringing this down to the lower eyelid and suturing it into the lower eyelid here. So you can see these black sutures. This tissue is the tarsal plate coming from the upper eyelid, which I sutured to reconstruct the posterior lining and support of the lower eyelid. So this reconstructs the back of the eyelid, so to speak. So now what I did here on the right side is we support the corner of the eye with something called a canthopexy, which supports and creates tightness to the corner of the eye so it doesn't droop. And then I've lifted up all the skin tissue, and the whole idea is that I'm going to advance the skin upwards in order to reconstruct the skin component of the eyelid, or the front of the eyelid. And so this is her right after surgery here. So you can see this membrane is bringing blood supply to that tarsal plate, reconstructing the back portion of the eyelid. And now all this kind of bruised skin is very, very thin skin from the cheek and lower eyelid, which I advanced upwards in order to reconstruct the lower eyelid front surface. So this is a two-stage procedure. So obviously she's going to have her eyelid, believe it or not, sewn shut for a period of time, for about 3 weeks. And this is what it looks like after 3 weeks. You can see how bruised and damaged this skin is right after surgery, but now it's gotten some blood supply, it's got some space, some ability to reconstruct its hardiness. And this tissue actually grows up on top of this little muscle membrane here. And so this is her after 3 weeks, right before I'm about to go and sever this connection to open up the eye again.
Can I ask a question?
Absolutely.
So when you reconstruct the skin by advancing the lower eyelid skin and cheek skin, there's a tendency that you know better than any of us for the eyelid to want to retract afterwards. So you talked about how you did was it a canthopexy or a canthoplasty? How did you support the eyelid to prevent that retraction afterwards?
Right. So right at the corner here on the inside of the eyelid, I placed a suture, a permanent suture that's secured to the bone of the orbit. And so what that does is it creates a little bit of a tightness or a sling. Imagine a hammock. If you have a hammock that loosens up over time, it's going to drop down. But if you tighten up the sides of the hammock, that hammock is going to stay nice and taut. So forces of swelling, the forces of scar contraction can really bring down the lower eyelid. So without that canthopexy, I could have done a ton of work here, but if I didn't do that canthopexy, that eyelid may drop down a centimeter or so. So that canthopexy is really key to maintaining the tightness of the lower eyelid.
And you said you use a permanent suture when you do that?
That's right, yeah, a foro-merceline suture, which is a braided permanent suture.
Okay.
All right, so moving on here. So this is right before I'm about to sever this connection. So we take the patient back to the operating room, and what I do is put a little safety instrument so I don't hit the cornea, and I simply divide that segment with a little knife to basically open up the eyelid again. So you can see here in this photograph, the eyelid is inverted. That's the section from the upper eyelid. The little wound that we see here is where we took tissue from the upper eyelid and moved it down to the lower eyelid. And now this is the new eyelid position here. Now things look very bruised and battered here. Doesn't necessarily look exactly like an eyelid, but if you look at the position of her eye here, that's actually in good position. So this is her before surgery right here, okay, with the wound. And this is her after surgery about a year later. So you can see here the lid position on both sides looks equivalent. And the only difference here you see is this just ever so slight redness to the lower eyelid. Now, if you look very closely here, she doesn't have any lashes here, obviously, because that skin that we brought forward or up does not have any lash-bearing component to it. But with a little bit of makeup, sometimes a little bit of tattooing will do the job. That tends to work fairly well for patients. And more importantly, she's able to function and keep her eyelid closed without difficulty. I would be hard-pressed to say that anybody that looks at her from across the room or in a conversational distance would notice that she had 80% of her eyelid removed.
That's a great result. Very difficult reconstruction, and that looks remarkable.
You know, Sal, when you work with your team, it's got to be tough because with Mohs, you don't know what your final defect is going to be until they complete their resection and margins are clear.
That's right.
How often will you get these, you don't know if you're going to get a very small reconstruction to handle or a very, 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 very big one.
Right.
How do you handle that?
So two things I would say. I got another case to show you, but let me stop sharing for a second so we can chat. So very good question. So how do I predict how much is going to be resected? So the number one is I always see these patients in consultation ahead of time. So it's sort of intuitive that we would need to do that. But to be quite honest with you, if you're a plastic surgeon around the country dealing with various dermatologists or Mohs surgeons, many times what happens is you get a frantic call on a Friday afternoon that this patient has a big hole and we need to do something about it, right? So you don't have the luxury of planning ahead of time. So fortunately, I have a handful of Mohs surgeons I work with, and we have a really good multidisciplinary process for evaluating these patients ahead of time. So with examining their photographs, examining their physical exam before the resection, I can usually have a 95% sure chance I'm going to either need to do it in the office or in the operating room. So in general, most of the eyelid procedures I tend to do in the operating room just because it's a little bit more comfortable for the patients. But every once in a while, like on the cheek, say, it gets a little bit larger. So I know that if the patient has gone for 3, 4, 5, 6 rounds of Mohs surgery, I'm going to need to probably delay their case in the office and take them to the operating room. And I think in general, the key is you have to be prepared with a plan A, plan B, plan C. You have to know enough about these types of reconstructions to plan everything ahead of time.
Very good.
All right, so now I have a little video here. So I'm going to just share my screen again here. It's just a quick video. Sorry for the faint at heart here. This is a little bit of a larger reconstruction, and I want to show you, gents, here. Okay, so you can see this video here. Okay, great. All right.
Yep.
Okay,
Right.
so this is a video that was featured in my textbook here. So so I'm just going to kind of fast forward here. So this is a gal who had a skin cancer that you can see diagnosed ahead of time. Unfortunately, this was present for many, many, many years. And if you look here, this is her left nostril, which is normal. And then you see her right nostril, and you see this kind of white, pink plaque here. So what do you guys think about this here when you see this?
This is a complicated, when they're done with the Mohs surgery, she's going to have a large defect that it kind of goes beyond what we have time to discuss, but it's going to involve multiple subunits of both the nose, and it's also going to involve the cheek. So reconstruction is going to involve not just fixing the hole, but fixing the hole in a way that's going to require her nose to still look like a nose. So the side of the nose is going to need to be reconstructed in a way that's different than the cheek. The nostril rim, which we call the ala, is going to need to be reconstructed as well. And so it's a fun case, complicated reconstruction, because you have to think about each area separately as you do the reconstruction.
Yeah, so this is so the thing that struck me about this case is we're not even starting from a normal position here. We're starting from an area that has already been eroded substantially by skin cancer. So when I'm planning this reconstruction, I have to think what normal looks like, not what pre-operative Mohs surgery looks like. So that's the challenge here. So so let's kind of fast forward here. I want to show you her. Okay, all right. So this is her defect here from Mohs surgery. So you can see here, this involved a good chunk of the cheek, a substantial portion of the lip, a section of the ala of the nose, which is this round portion of the nose, and a couple segments of the nose, which is called the nasal sidewall. So this is a huge challenge. So obviously this is somebody that's going to need to go to the operating room. We have to think about preserving the nostril function, not just the nostril appearance. So we're going to have to line the nose, the inner surface of the nose. We're going to have to use some tissue support to the nose. And then we're going to have to do multiple stages of reconstruction to get this lady looking close to normal here. So what I did was a 3-stage procedure here. So my video player. Okay. So here we are. So basically what, I should have gloves on here. Sorry. So what I did was I used a piece of tissue to build the foundation of the corner of the nose. So this is what's called a V to Y flap. This flap goes in to the center portion of the nose here to build some structure and foundation for everything to be built upon. I have this other small piece of tissue to reconstruct the lip, which I bring upwards to reconstruct the corner of the nose called the ala. So now you can see here, I've put a little piece of cartilage in the nose to reconstruct the lining to maintain the tissue support. And now I have this substrate or this foundation that I'm sitting right here that I know I can build tissue upon myself. If I were to just take tissue and put it into the hole, it may collapse on itself. So I need a little bit of extra substrate of tissue. So what do we do to reconstruct this corner of the nose? We're going to use some tissue from her forehead. So this is what's called a forehead flap. So this flap is designed by an artery near the eyebrow, and this artery gets rotated, or this flap of tissue gets rotated down to the nose right here, and it's going to stay in position for a period of several weeks in order to bring healthy, thick blood supply to the site. Okay, so now I have this flap in position right here, and that's going to reconstruct the ala. So over time, this segment of the forehead flap is going to go away. Okay, so now what I'm going to do here is I'm going to thin that flap. So it doesn't really still look like a nose right now. It looks very thick and bulky. So I'm going to take this opportunity at the second stage of surgery to aggressively thin this flap out so that it looks and contours like a nose. So what we do is we leave it attached, and then I go on the inside and I thin this area out a bit, and we replace the flap back into position to make it just as well contoured. Now, about 4 weeks later, we're going to do the final surgery called the division and insetting. And what that involves is I'm going to take out the segment that's going from her eyebrow to her nose so that everything can get back into position here. So now that it's now grown its own blood supply, we've removed that segment here, and I'm going to clean up this segment so that it gets well sculpted to look exactly like a nose. Okay, so now this is her going forward. Okay, so this was her original defect, as we talked about. Okay, and now the video player is a little lost here. Okay, here we go. So this is her after the fact. You saw that big hole she had in her face, and now this is her in the office. Clearly, we have some scars here, but the key here is those scars will fade over time. They can be covered with a little bit of makeup, but the nostril rim is what we're looking at here. And you can see this nostril rim is substantially bigger and thicker than it was even before she had her skin cancer removed. What I'm using as a model is the opposite side of the nose, not necessarily the preoperative side here. So that will reconstruct her her nostril ala, that corner of the nose. And you can see here, we've got a little bit of tissue thickness, a little bit of tissue bulk here. We can always revise this over time, but this is the difference between before, during Mohs surgery, and then after, about 6 months afterwards.
That's great.
So,
well, I think, Dr. Pacella, you are humble as always, but that is an amazing reconstruction and a really good illustration for, I think, the people watching this show that, one, wear sunscreen so you don't end up in that situation, but two, should you not and you develop a problem like that, there are solutions. But I want to congratulate you. Those are phenomenal results, both of them. And I particularly like the illustration of the forehead flap, just so our viewers can really see how complicated the reconstruction can be.
Yeah, right. You know, as I mentioned, this is a topic and a discipline of plastic surgery that I just am truly passionate about. I think it really is taking a segment of the body that's been destroyed and attempted to rebuild it to a state of normality. I mean, it's very similar to what we do in cosmetic surgery. In fact, it's probably the ultimate cosmetic surgery. We're taking a deformity and making it as inconspicuous as possible. So,
I know you lecture nationally about this, and I think you just did at our national meeting recently about this. So, yeah, this is not for the run-of-the-mill plastic surgeon. This is for, this is high-level reconstructive stuff that is absolutely creative. It builds on multiple principles. You have to be, you have to have skill as well as a high level of creativity in order to achieve those kind of results. So that's amazing.
Thank you, Jess.
Right. Well, with that, let's wrap up yet another great episode of this show. Dr. Pacella, thank you again for imparting your knowledge, both to Dr. Rhee and myself, and to all our viewers. And until we meet again,
wear sunscreen.